Hi, I'm Eva Huismans, a member of Pain in Motion, and I'm attending the EFIC conference. And I'm sitting here with Dr. Adriaan Louw, who is famous, of course, for his research in pain neuroscience education. So, Adriaan, as an expert, where do you think pain neuroscience education is going in the future?
Oh, that's a really good question. I think if you asked me a year ago, I would have told you there's direct paths we're going to follow, but I think there's so many cool things that have come out that, to be honest, even today at EFIC, I'm myself asking a question. I can say a few things, but I think it's evolving, right? So yeah. I think the pain neuroscience education is going is, first of all, the idea of subgrouping. We know there's a subgroup of people that will respond really well to this and another group won't, and we're going to find who they are. So this brings us to the big question about who needs it, right? There's this idea that does every patient need it? And the answer is an overwhelming no. But who needs it? Can we find that? I think the idea of pain education for the world, to take it to the masses. You and I have talked about a study and those kind of things, but the idea that we need to take it to the globe, if you will. That's a big part of it. I think there's so many challenges with digital stuff like telehealth. No matter who I speak to in the big world and ask them where will we be 20 years from now, the word telehealth keeps coming up. So we're going to have to get that out there, right? I think those are some of the most common things. Who needs it? Telehealth, getting it to the masses. Those are probably some directions. I'm sure there's more, but those are the ones that's running through my mind right now.
Yeah. And is your group at this moment doing some research about these future directions already? Or?
Yeah, we are. I think the idea of who needs it, we're getting ideas about things like people with high catastrophization, things like high field avoidance, simple sensitization. But there's also the behavioral models of contemplation, pre-contemplation. So we're doing a little bit of that work from the behavioral side. I think there's also the idea of taking it to people with acute pain that have some of these characteristics like the talk we're going to be on, right? Yeah. I think those are some interesting ideas. Taking it to the masses, a lot of our work right now is to take it to school kids. I think there's a place, I remember years ago, David Butler and I had this conversation about we need to take it to people that are not in pain and teach them this so when they do get into pain, they go, I got it, I understand what's going on. So those are some areas we're playing with. We're still doing pre-surgery stuff, which I think is critical, because that area is big into fear, catastrophization, and so on.
So another question. I've seen some of your presentations in the past, and a thing that keeps popping up is the principle PNE+. Can you give some explanation about it?
Yeah, and I think a lot of the scientists at Pain in Motion is validating this, or they validated it and we figured afterwards. But unfortunately, there's a lot of people who believe you can explain pain away from people or out of them, and that's not how this works. What we're beginning to acutely understand is that when you explain to people how pain works, there's a behavioral shift to the things like movement, right? And the thing that makes it better is movement. So when we did our review of our systematic review, Corey Zimney, one of our colleagues, basically ran a statistical analysis to show that if you look at PNE as an entity by itself, I only explain pain to you, that's it, versus doing that plus something physical, be it some type of movement, the effect size is way better on that. And so we then looked at it and said, what did they do in these studies? Well, it's PNE plus exercise, PNE plus manual therapy, PNE plus neurodynamics. So we came up with the idea it's PNE plus something else. And what I like now as a physio is the idea it's PNE plus physio. And then what is that physio? Well, that's the fun part. And it typically involves movement. And if you look at some of the research your group has put out, it is incredibly powerful when you combine PNE as a primer to prep you to do movement. And then movement's what makes you better. And that's why when you ask me, where's PNE going? I don't know, because until a while back I would have said, oh, it's going to do this and this, but now we're seeing it's more than just the education.
Yeah, so what you're saying is that it's more like a primer for the rest of your therapy.
Absolutely, reducing fear, catastrophization, changing your beliefs about pain that allows you to move. And it's movement that makes you better. It's not the PNE, but it alleviates fear that makes you move. So absolutely.
Yeah, I can totally agree with that also. You're also working as a clinician in the clinic a bit, and you're also, of course, surrounded by a network of clinicians. So that's why I want to ask you, do you think there are certain barriers for providing PNE to patients that clinicians often experience? And if they tell you about those barriers or you experience them yourself, what would you advise to them?
Yeah, I mean, we did a study. We surveyed over 700 therapists that use PNE every day, asking, what are the barriers? And the number one barrier always comes with biomedical. They are so biomedically trained, number one. Number two is the providers, the physicians. Another one which is intriguing is our knowledge of PNE, our ability to do it. So I feel comfortable, I think you're comfortable, Joe is comfortable. There's people that are getting better, but most clinicians don't feel they're good enough yet to do it. So those are some of the barriers. Personally, I believe in number one. I think the biomedical model is so powerful. When people walk in and the doctor says this and the surgeon says this and Dr. Google says this and it's on Wikipedia and they believe in this thing, and to change that belief is incredibly difficult.
Yeah, that's true. One last question. What are for you the highlights of EFIC 2019?
Wow, it's hard to answer on day one, isn't it? This has been amazing. I mean, I'm here with Corey Zimney. We came over and we already sat through this morning session. The session this morning on hypoalgesia, exercise-induced hypoalgesia, fits so well with PNE and PNE+, right? So that was, wow, so cool. And the reason I was excited is because that is a real thing we can do tomorrow in the clinic. Because we can build an aerobic program, an isometric program, and by the way, the intensities may matter, may not matter, and something. That's something I can translate tomorrow for a clinician in a real clinic. Which, EFIC is going to be cool and all these conferences, but we got to put it in a clinic. And so that's a part. And then I have to mention it. I've read Marshall Devore's work for years, never met him. Today I met him for the first time, so to me it was like, yay! I got to meet him. Unfortunately, went heavy to the pharmacology, medicine side, so I'll have to go talk to him a little about the rehab side, but that was cool, and we just started today. We haven't even started for the rest of the week yet, so.
Okay. That's it. Thank you for the interview.
Sure, no problem.